Hello everyone. Today I would like to talk about how to prevent heart failure pandemics. So the heart failure is a really serious issue among all over the world and also cause a lot of trouble of cardiologists. So in Japan, now cardiologists are overworked. So we ask the GPs to treat or to prevent heart failures before they get symptomatic heart failures. Okay, so I would like to talk about can prevent how the GPs can prevent the heart failures. So this is the guideline from the US, HA and ACC guidelines. So classically, we classified the heart failure as a NIHA's classification 1, 2, 3, 4. But nowadays, a risk for heart failure is a pre-heart failure, and stage C is equal to symptomatic heart failure, and stage D is advanced heart failure. They reclassified the heart failures. Very important thing is they include the pre-heart failure and our risk for heart failures are stage A and B. So today's topic is how to manage stage A and stage B heart failures, not in severe heart failures. So we will focus on these patients. Okay, they are at risk for heart failures, but without any symptoms, any sign of heart failures, without any structural or functional heart diseases or abnormal biomarkers. So BNP are normal, ultrasound are normal, and also the patient is free from the symptoms. But patient has hypertension, cardiovascular disease, diabetes, obesity, or cardiotoxic agents such as a chemotherapeutic agent, or genetic variants for cardiomyopathy or familial history of cardiomyopathy. So those are the risks to develop the symptomatic heart failure in near future. So the patient with these risks should be treated by GPs or general practitioners or internal physicians to prevent the developing of the symptomatic heart failure, and also release the cardiologist from advanced heart failures and let them have more free times. Okay? So pre-heart failure is a little bit advanced from the at risk for heart failures. So pre-heart failure patients are without any current or previous symptoms and signs of heart failures, but the patient has any one of these findings. Structural heart diseases, so we can detect by ultrasound, or evidence of increased filling pressures when we insert the catheters or we measure the filling pressures either by the directly or indirectly. The patient has increased filling pressures. They are very easy to develop symptomatic heart failures. So they are defined as pre-heart failure. And also the risk factors such as the high in BNP or persistent elevated cardiac troponins in absence of competing diagnosis. So if patient is apparently ischemic heart diseases, so it's not a pre-heart failure stage. Okay, so those our risk for heart failure and pre-heart failure should be properly treated by the GPs and physicians, not necessarily by cardiologists. But the guidelines in circulation, HA guideline has a diagnostic algorithms for patient with suspected heart failure. So the patient with high risk or not symptomatic, but risks for the developing heart failure, stage A and B. So we assess the clinical history, physical examination, ECG, and also blood test. Especially the BNP or NT-proBNP is important for the patient who is suspected for heart failures. So they set the cutoff. In case of NT-proBNP is above 125 or BNP above 35 has risks or should be evaluated if they have really heart failure or not. So usually the second step we use the echocardiography and also additional testing if necessary. So for example, cardiac MRIs. And also thoracic echocardiography, as I give a talk the other day, that not only EF or Doppler ultrasound or Doppler tissue Doppler evaluation, but also speckled pattern, speckled analysis is important to evaluate EF and diastolic functions to diagnose the patient with heart failures. And when these further examination show the apparent heart failures, then heart failure is diagnosed, and then we look for the cause and classify it. So classically, we classify the patient, those who are reduced ejection fraction and preserved ejection fraction. So we call them HEF-REF and HEF-PEF. Sometimes we abbreviate it REF and PEF. But these days, we have new classification that is in the middle. So EF between 40%, 40s, so 41% to 49%. Classically, they are classified as a REF, but nowadays we separate them from REF to PEF. In between REF and PEF, we set MRF-EF. So we have now 3 classes of the heart failures according to their ejection fractions. And also, do we evaluate the precipitating factors, or for example, the ischemia or diabetes or hypertension or cholesterolemia or those kind of stuff, and then start treatment. Especially the very latest issue of New England Journal show that patient after the acute myocardial infarction and then recanalization has done. So those patients are very easy to develop the REF. So in that case, those patients, they try to show the efficacy of early administration of SGLT2 inhibitors, and the results showed they failed to show the efficacy of very early administration of SGLT2 inhibitors in general population with acute myocardial infarction. Of course, the patient with diabetes or CKD, they are very high risks. They may have some benefit from giving the SGLT2 inhibitors as soon as possible after the ischemic attack. That is very prominent in contrast to ACE inhibitors or beta ACE inhibitors that should be given right after the onset of acute myocardial infarction. Both ACEI and SGLT2 inhibitors are very effective to treat the REF patient with symptomatic or reduced apparent heart failure. But in case of early phase, the when to start those drugs is different from ACEI to SGLT2 inhibitors. That is shown the recent issue of New England Journals. So please take a look. I don't have time to make slides from that article because it was published today. Okay. So these are the initial classification of REF and the mid-range REF and PEF, so according to the LVEF. And furtherly, we subclassified. The serial assessment of the reclassification is shown here, but this is not topics here. Today's topic is how to prevent those heart failures. Today's topic is not after the developing apparent heart failures. So this is Japanese guidelines. We define that heart failure is very likely when BNP is less than 20s, and 35 they set the cut off. Heart failure is unlikely but needed to follow-ups, and 100 is a definite cut off to diagnose uh, heart failures, and above 200 they are high risk of CHF. And they recommend, the Cardiology Society recommend the GPs to consult with cardiologists if patient has higher than 35 BNP or 125 NT-proBNP. And this is based upon the paper published formally, and they say that BNP above 34 has very high negative predictive value, that is 99.5, and for LV dysfunction and LVH. So then they set the 35 picogram per ml for the cutoff of heart failure, pre-heart failures. And then you recommend the GPs to send the patient to the cardiologist. If this is done very strictly, the cardiologist has to pay a lot and lots and lots patient. And this is not correct interpretation of the data. I would like to discuss how to set the cut points to diagnose or rule out the diseases. So this is also, I have shown in the previous lecture, that this is the data from the BMJ 2015. They did a meta-analysis of BNP sensitivity and specificity to diagnose heart failures. So when they set the cutoff 100 nanogram per liter, the sensitivity is 0.95 and specificity is 0.63. And this means that if we collect the 100 cases of heart failures and 100 cases of non-heart failure patients, so BNP above 100 is 95, and BNP less than 100 is 63 patients among the normal cardiac function patients. That is the 95% of sensitivity and 63% of specificity. So sensitivity and specificity is calculated in this row. Okay. So the positive predictive value is calculated as in this column. Okay. So 95 is divided by 95 plus 37. So the positive predictive value is only 75%, 71% if the BNP is above 100. So if you see the patient who has BNP higher than 100, it means the patient has heart failure in 71% of the likelihood. Okay, and if patient has negative, so I mean if patient BNP was below 100, it means 92% certainty that we can say that the patient is free from heart failures. So that is a positive predictive value and negative predictive value. But of course, it depends on the morbidity of the heart failures. So usually we set this cutoff point by drawing ROC curve, receiver operated curve. So we set the points very close to 1.0, and 1.0 here is the very good cutoff point. So if the test is no meanings, ROC curve is on this one, Y or X linear relations. But usually all the clinical index has a positive ROC curve, but to set the cutoff point is very essential, or we miss the diagnosis. Okay. So as I told you, that the positive predictive value and negative predictive value depends on the morbidities. So in the former slides, I calculated positive predictive value and negative predictive value under the 50% of morbidities, as shown here. So if the morbidity is 50%, so disease plus and disease minus 500 and 500, And when sensitivity is 80% and specificity is 90%, we can calculate positive predictive value as 89% and negative predictive value as 82%. Okay, you can calculate quite easily. And if the morbidity is only 10%, so we have the disease cases 100 and the healthy cases 1,000. So in that case, the same sensitivity and specificity, but the positive predictive value and negative predictive value dramatically changes to 0.44 and 98% respectively. So when we know the sensitivity or specificity of each exams or test. We don't know, if we don't know the exact morbidity of the certain diseases such as heart failure in that specific cases. So if you see the patient with a 68 years old male, we don't know the correct morbidity of the patient of the heart failure in patient with male 68 years old. So we cannot calculate positive predictive value or negative predictive value correctly. So to overcome this problem, positive likelihood ratio and negative likelihood ratio is used. This is only calculated by sensitivity and specificities. Okay, so sensitivity divided by 1 minus specificity is positive likelihood, and negative likelihood as shown here. So let's calculate the positive and negative likelihood ratio. So this is the same case, sensitivity 80% and specificity is 90%. So as I showed you before, the positive predicted value and negative predicted value is diverse according to the morbidities. But when we calculate likelihood, we can get the same result. So positive likelihood ratio was 9 and negative likelihood ratio is 1.11. But this is not the odds. So we can say that the percent of the likelihood by calculating the positive predictive value and negative predictive value. But we have to change this to the likelihood, okay, odds, to how much certainties we can have using this specific examinations. So usually we use it's sometimes annoying. So we have this kind of formulas that if the likelihood is 2, it's increased the possibility to 15%. If the likelihood is 10, the possibility is rise to almost 50%. So the positive likelihood is higher, the better. And the negative likelihood ratio, lower, the better. So when we set the cutoff of BNP 100 and 500, when we compare it according to that paper, the sensitivity is 95% and 63%, and 35% and specificity is 78% accordingly. So we calculate positive likelihood ratio and negative likelihood ratio. It's 2.6 and 0.08. And if we set the BNP cutoff as 500, it decreased, the positive likelihood decreased to 1.6 and negative likelihood increased to 0.83 as shown here. So when we set the BNP as 100, if the patient has the BNP higher than 100, we can say that his possibility to have heart failure is increased by 15%. But if the patient is lower than 100%, so negative likelihood is 0.08, that means he is very unlikely to have the heart failures. So the 100, less than 100, can be used to rule out the heart failures. So if we set the 500, of course the specificity is increased, but the likelihood, as shown here, if the patient has higher than 500, the likelihood is only 1.6. So the possibility to have the heart failure only increase 10% or less. And if the patient is lower than 500, the possibility that patient doesn't have hypertension, heart failure, is decreased only 10% or less. So it's almost nothing. It's meaningless. So we recommend you to use the cutoff point as 100 to rule out heart failures. So we look for the original papers that our guideline cited. They cited this paper from Circulation 2004, and they said the BNP partition values in population, age, men, women, high-risk men, and high-risk women, and set the BNP cutoff as 54, 75, 54, 98, 63. And when we our guidelines just calculated positive predictive value and negative predictive value by using this sensitivity and specificity without knowing the morbidities. But when we use the likelihood, we can see here. So the positive likelihood is very high in men when we set the cutoff as 54, and in women, the cutoff should be set 98.5. That means nearly 100. Okay, and when we take a look of negative likelihood, the negative likelihood is very low in general population when we set the BNP cutoff point as 54.5, or in men 54. So it's almost like 50. So 35 is too exaggerated, and the data is misinterpreted. So I strongly recommend you to use 100, or in some cases for men has very high risk for the developing the heart failure. We set 54 as a 50 or 55 should be set as a cutoff point to diagnose or rule out the heart failures. But this is only one data. As I show you that in BMJ, they did a meta-analysis, and they claim that 100, the BNP above 100 is a very good cutoff point to diagnose the heart failures. And I would like to follow them. So I still use the 100 as a cutoff point in my personal practice. And also I teach them to medical students with these evidences. Okay? So, and also they cited this paper, Journal of Hypertension, back to 2000, and for the left ventricular hypertrophy or left ventricular dysfunction, this paper shows the sensitivity and specificities, and they claim that the positive predictive and negative predictive value is very good when we set the 34 as a cutoff point. But when we calculate the positive likelihood ratio or negative likelihood ratio, it's merely 2.0 and 0.83 for left ventricular dysfunction, or for left ventricular hypertrophy, it's only 2.4 and 0.79. So that is only increase the possibility of left ventricular hypertrophy or left ventricular dysfunction about 10%, or we can rule out them only by 10%. So in clinical setting, I don't want to use the 34 or 35 using this citing by this paper. This is not scientifically correct. So I strongly recommend you to use 100 picogram per ml for left ventricular dysfunction or left ventricular hypertrophy as well. So let's move on to the next topics. Usually we have a lot of patients with ischemic heart diseases and then develop the heart failure. So the prevention of ischemic heart disease is very important to prevent the heart failures. So of course we use the statins and sometimes anticoagulants or other devices, or we use the renin-angiotensin inhibitors or beta blockers to prevent the angina to progress to the ischemic heart diseases. But also we have a lot of causes of non-ischemic origin, the reason to develop the heart failures. For example, recently we have a lot of patients who can survive after the chemotherapy, especially not only the hematological malignancies, but also the liver disease, liver cancers, or gastric cancers, or colon cancers. We give a lot of chemotherapies, and the cancer can be eliminated successfully. So they live longer, but chemotherapy, some drugs causes heart damage, cardiac muscle damages. So in that case, they will develop heart failure later on, like 2-3 years after the remission of the malignancies, and then they would die due to the heart failures. So this is very important. So you should take medical history very carefully. What kind of chemotherapy or cardiotoxic medications they have taken. And also rheumatologic or autoimmune diseases are very important to develop heart failures. Like my lectures on amyloidosis, of course, rheumatologic or autoimmune disease is one cause of the amyloidosis in the heart. So they will develop heart failure quite easily. And also endocrine or metabolic diseases, thyroid dysfunction, acromegaly or pheochromocytoma, and of course diabetes and obesity are two very big risk factors to develop heart failures. And also familiar cardiomyopathy or tachycardia or PVCs, also hypertension, and also as I told you before, the amyloidosis or sarcoidosis, and also hemochromatosis is a risk to induce the heart failures. In my lecture on obesity, I thought that the obese patient is likely to develop iron deficiencies. So if you give high dose of ions to those patients, they may have the risk to develop hemochromatosis and then develop the heart failure. So you have to pay very high attention on ferritin levels and iron levels if you give the ferrous drugs to patients with obesity. And also myocarditis is very big topics after the COVID pandemics. So COVID can cause the infectious myocarditis. So we pay very high attention to patients who are admitted after the COVID, or patients who are not necessarily admitted but have heart failures that may be due to the COVID infections. And also adenovirus or other virus can cause the myocarditis, and some patient requires cardiac transplantation. I don't know if you do the cardiac transplantation in Kazakh, but in Japan we have very rare, very small number of the cases, but still we do cardiac transplantation. The patient with the familiar cardiomyopathy or genetic heart diseases, and also myocarditis after the viral infection or alcoholic. We don't do the alcoholic myocarditis, but mostly the viral infections. Okay, and also the pregnancy-induced cardiomyopathy is a big deal among the young ladies. And also takotsubo cardiomyopathy. That is, takotsubo is Japanese. It's a nest of the octopus. So tako is octopus and tsubo is nest. So it's the shape of the takotsubo cardiomyopathy is very look like the nest of the octopus. So that we call takotsubo, and it's now worldwide used. I'm very proud of it. But anyway, stress cardiomyopathy is also developed heart failures. And also substance abuses, alcohol, cocaine, and methamphetamines. I don't know if it's very popular among the Kazakh, but I'm sure that you drink a lot. So alcohol-induced cardiomyopathy might be a very big issue in Kazakh as well, so as in Japan. So the prevention of heart failure, of course, we treat them by the drugs, but also the lifestyle modification is a basic treatment to prevent the heart failures. So stop smoking, quit smoking, and better yet, but don't start. So we have the classes for the school kids, especially the high school students. We give lectures. This don't start smoking. Okay. In Japan, they can, legally the age of 20s they can start smoking. So we teach the high school students and freshmen and sophomore of the university students who are younger than 20s and do not start smoking. So we show the slides of the lung cancers and cardiomyopathy and heart failure patient and stress them. The smoking is very harmful and nothing to do with good things. So we teach them. That is very essential. And of course, the patient who are smoking, we let them stop smoking, definitely. So all the facilities, medical facilities or properties of the hospital is non-smoking policies. And also recently, about 2 years, we have very strong, very strict non-smoking policies. You cannot smoke in public. Even in the park or on the road, it's strictly prohibited to smoke. So as the electrical cigarette. So electric cigarettes, sometimes they think it's safer than the regular classical smoking, but it's not true. The electrical smoking is also very high risk to develop the cardiovascular diseases. So I instruct the patient, not only me, but also the pharmacist or dietitians, nurses, all the staffs, medical staffs, teach, instruct, or educate the patient. Every time they visit our clinic, I ask the nurses to educate them, I ask the pharmacist to educate them, okay, to stop smoking. And also eat in heart-healthy ways, so avoid too much calories and also the oils and fat. And of course, especially the oxidized fat is bad for your endothelial cells. So educate them to eat heart-healthy ways. And also the reduce the sodium intake. And I would like to talk about the sodium replacement by potassium as one way to protect the heart. And also the obesity is our enemy. So please refer to my the other talk about how to fight with obesities. And in that lecture, I talk about the both surgical and also medical treatment of the obesities, and that those can prevent the cardiovascular diseases. Okay. So this is the data from the Lancet 2020. Even after the COVID, still the risk factors for developing heart failure is the high systolic blood pressure both in females and males. Of course, males tobacco is very high, but the high blood pressure comes the second. But still, it's very high risk to develop the cardiovascular disease, and also dietary risks. If they eat too much salt or too much sweets, that will be a risk to develop the cardiovascular diseases. This is the study on global survey of the nutrition and disease prognosis. So it can be applied to Kazakhs as well. So now we know that heart failure progresses year by year, and if they have several attacks of heart failures, the prognosis is very poor. So we have to prevent the progression of heart failures. So hypertension is one of the leading cause of the coronary artery disease and MI, and leading to the HFrEF. And also hypertension itself is a risk for HFpEF. Okay, so we should treat the blood pressure as low as possible. So this is the one case, the lower blood pressure is good for your health. And this is called SPRINT trial done in the US. So they use the many drugs to lower the blood pressure. The target blood pressure was less than 120, and regular treatment is less than 140, and they observed the patient for at most 5 years. And you can see here the intensive treatment, that is the blood pressure lower than 120, has better prognosis in cardiovascular diseases and the all cause of mortalities. That means the death of the patient. Okay? So, but of course, it's very surprising, and we are encouraged to lower the blood pressure as much as possible in patients with hypertension that can prevent development of heart failures. But before to conclude that, I would like to calculate NNT, number needed to treat. So how much the lowering blood pressure is effective to prevent the heart failures? How many patients should I treat? Then I can save one life. That is number needed to treat. So when we take a look of this paper, the cohort was around 4,000, okay, in both groups. And primary outcomes, that is heart failure and any cause of mortalities, number was 264 versus 354 in regular treatment. So that looks very effective to reduce the primary out point. And of course, it's p less than 0.001. So statistically, of course, it's effective. So the most of the doctors believes that the lower blood pressure less than 120 is effective. But when we calculate number needed treated, so that is 4,600 divided by the difference of the cases. So 354 minus 264, it is 50 in 3 years. So when we treat 50 patients, then for 3 years, then we can save only one patient. So do you think is it effective? I don't think so. So we have a lot hypertensives, but only 1 out of 50 can be saved by lowered blood pressure in lower than 120 using the multiple drugs, 4 or 5 drugs, including ACE inhibitors, calcium channel blockers, thiazide, beta blockers. So that costs us a lot, and the effectiveness is only 50%. But when we think about how long we see the patient, it's not 3 years. The patient with hypertension can develop heart failure maybe later on, like 10 years of history of hypertension will develop the heart failures or myocardial infarction. So usually we follow the patient more than 30 years in some cases. In my case, I finished my medical school in '88, and I'm following the patient since then. So the longest patient is more than 30 years. So if we treat the patient for 30 years, this is only 3 years result. So if we treat patient for 30 years, so we can divide it by 10. So one out of 5 patients are saved if we lower the blood pressure very strictly less than 120. We can save them from the cardiac events and all cause of mortalities. So that will encourage me how important to lower the blood pressure to prevent the progression of heart failures. Well, when we look at the heart failure, only heart failure, this is the primary outcomes. But when we look at the heart failures or non-fatal heart failures, we can calculate NNT for 3 years is about 64. So, patient with hypertension can develop heart failure maybe 10 years after the initial diagnosis of hypertension. So even if we divide it by 3, we need to treat at least 20 patients, okay, for 10 years. Then we can prevent the heart failures. So the blood pressure itself is, of course, very important, but it's not the sole the treatment. We should take care of the other risks, such as inflammations or diabetes hypercholesterolemia and obesity, less exercises, those kind of stuff. We have to treat all of them all together. Okay? But if we follow the 30 years, we can save the 1 out of 6 patients. But you know, the patient who developed heart failure cannot survive 30 years. So this is not this is meaningless. So usually we calculate about 10 years for the NNT to prevent heart failures. Okay? So the salt is one of the leading cause of the developing high blood pressure, hypertension. So how we can reduce the salt? Of course, we educate them to avoid salt, and salt also increases the inflammation. So reducing salt will not only lower the blood pressure, but also reduce the inflammations. But it's very difficult for us Japanese who very like to eat salty food. We use a lot of soy sauce and salt as a spice. Of course, to preserve the food, salt is very effective, so it's okay. But to reduce the salt as low as 6 grams is recommended by our societies. We don't know the best way to reduce the salt yet. And here, this is the published 2 years ago in New England Journal from Chinese groups. They replaced the sodium by potassium. So here you can see the 24 hours urinary sodium excretion is decreased after 12 months from 42 to 35. Okay, so the replacement of the potassium can reduce the salt intake. That is equal to 3 to 4 grams reduction of salt. So if patient is taking more than 10 grams of the salt, we can target the 6 grams of the salt intake by replacing potassium. Okay, and also they confirm that they are taking the potassium. You can see here the urinary potassium levels very increased after the 5 years. But that means even if you replace this sodium by potassium, potassium will not accumulate. They can be excreted in the urine. So the hyperkalemia is not a common side effect after eating the high potassium diet, unless they are free from the renal failures. Who, patient with renal failures, they fail to excrete potassium because of the tubular damages, especially in the distal nephron. So they are easy to develop hyperkalemia. So you have to pay attention. The patient with the lower eGFR or proteinurias, when you educate the replacement potassium to salt, you have to pay attention. But still, okay, generally speaking, the high potassium diet is effective to reduce the high salt diet. Okay, then what is the outcomes? The systolic blood pressure lowered about 4 to 5 millimeter mercuries, and diastolic about 1 to 2 millimeter mercuries. Of course, this change is very subtle, so we doubt if it can prevent the cardiovascular events. But the answer is yes. As you can see here, the total ACS and total heart failure is reduced by the potassium supplementations compared to the control groups. Because the total sudden death was not was comparable between two groups, and also the arrhythmia was not prevented by high potassium diet. But here, the heart failure was effectively prevented by using the potassium replacement. Okay, so this is the data, how the potassium enriched salt compared to the regular salt on heart failure, arrhythmia, and the sudden death. And you can see here, it's very effective for fatal heart failure or non-fatal heart failures, but not in arrhythmias. Okay, so here you can see the p-values or ratio is not statistically significant in those risks. But when we calculate I would like to calculate the number needed to treat by potassium to prevent fatal heart failures. Number needed to treat is about 1,000. So you need to treat the 1,000 patient with a high potassium diet, then you can save only one patient. So this is not individual. This is not applicable for individualized patient treatment. So this could be used as population-based strategies. So the government of Kazakh should encourage the companies, the food companies, to enrich the processed food with potassium instead of the sodium, and sell the very tasty sausage. I love it, horse sausages here in Kazakh. It should be cooked with high salt, not by high salt, but high potassium diet spice. Then the large patients take a high potassium sausage. Then we can in population-based studies, you can reduce the heart failure in Kazakh dramatically. Okay, if the patient, if you give more than the million people in Kazakh eat high potassium diet, we can save a lot people from heart failures, because number needed to treat is more than around 1,000. Okay. So this is the guideline from US. It's back to the same guideline as shown in the very first slides. So the risk for heart failures, stage A, the guideline recommends the blood pressure control and SGLT2 inhibitors, and also the cardiovascular disease is optimal management, and also multidisciplinary evaluation for the management. Okay, if the patient is taking the cardiotoxic agent, and also genetic screenings and counseling should be done in patients with inherited cardiomyopathies. And also we should follow the BNPs that is easily measured by drawing the blood pressure. Okay, measuring the blood, okay, for the BNP. And also a patient with high risk for heart failures should be validated for variable risk scores. Okay? So you may use any scorings to evaluate the risks for the developing heart failures. But in case of stage B, they already have known risks, so should be treated. Not only the lifestyle modification, but should be treated either by ACE or ARBs or beta blockers, and also genetic counselings or testings according to their risks or known disease conditions. Okay? So the most of the cases, the ACEI, either ACEI or beta blockers, is a very good indications to prevent the heart failure development in patient with stage B. But these days, the SGLT2 inhibitors or GLP-1 and ARNIs have a very good result to prevent the development of heart failures, and so as mineralocorticoid receptor antagonists. So it can be used to prevent the heart failure. Okay? Then where's the thiazide? Because I told you the salt is very important factors, risks to develop hypertension and also the heart failures. So this is the analysis for sub-analysis of sprint trials, and they compare the patient with thiazide and without thiazide and outcomes. And as you can see here, very first several years, the patient with thiazide has better outcomes, but finally, there's no statistical significance in thiazide usage to prevent the cardiovascular events. So why this happens? So cardiovascular events death patient was receiving intensive blood pressure treatment in the propensity score matching cohort. We can see here the thiazide minus and thiazide plus. When we compare the number of the patients who had the events is 10 versus 2. Okay, so of course it seems statistically significant, but when we calculate number needed to treat, it's merely it's about 100. So you have to treat 100 patients with thiazide, then you can save one life. Okay, so when we compare the other drugs using and lower the blood pressure from the sprint trials and heart failure and non-fatal heart failures, the risks were shown in the previous slides. So I inserted it here. And the number needed treated for 3 years is only 64. So this is 5 years and 100. So we can say that thiazide is not strong enough to prevent their development of heart failures. Although it can reduce the circulating volumes and the sodium, increase the sodium excretion into the urine and fight against the high salt diet. But still, its clinical effectiveness is low compared to combining other drugs such as ACE inhibitors, beta blockers, or calcium channel blockers. So, when I look at the textbooks, why thiazide is not so effective? Of course, thiazide is very good to reduce the sodium and circulating volumes, but at the same time, it can increase the plasmarine activities and aldosterone level that induce caloriresis and induce hypokalemia. So hypokalemia will induce insulin secretion, okay, and also it's a risk for inducing hypercholesterolemia. And also it can induce the hyperuricemia. So that is another risk to progress for the CKDs. So the uric acid can accumulate in the kidney to cause the renal damages. So thiazide has those bad side effects. But of course, it can reduce the calcium clearance in the kidney, so it can increase the serum calcium level that can be protective against osteoporosis. But we don't know yet. And also, please remember, we are using the ARBs or ACE inhibitors together with thiazide. In that case, RAS inhibition can prevent the hypokalemia. So those are not risks. Those we don't have to think about this when we treat the patient with RAS inhibitors together with thiazide. And thiazide possibly can prevent the cardiovascular diseases. But as I showed you before, in sprint trial, even though they are on RAS inhibitors, the thiazide is not effective as expected. So what other causes? Here, we should remember that the thiazide will decrease not only sodium resorption, but also magnesium resorption is blocked by thiazide. That will lead to hypomagnesemia. You're not so familiar with the hypomagnesemia or measuring the magnesium levels because the magnesium is rich in the cells and like potassium. So even if you measure the serum magnesium levels, we cannot tell the hypomagnesemia properly. We should measure the urinary magnesium level and together with the serum magnesium levels to evaluate in whole body magnesium levels. But you remember that in patients with toxemia, the very high blood pressure attack during the pregnancy, you inject the magnesiums, okay, to stop the conversion and lower the blood pressure. So magnesium is physiologically very important ions. So here is some papers. That's clinical experience and evidences. So pregnancy toxemias, in case of the pregnancy and toxemia, the injection of the magnesium intravenously can prevent the poor outcomes of the toxemias. And also the stroke and MIs, the infusion of magnesium can prevent or protect the brain and the heart from the further injuries. And some basic evidence that is very striking, that in 1984 in Science, it was reported that the magnesium can dilate vasculatures. So what is the mechanisms? Let's propose that the calcium channel blocking effects, because both calcium and magnesium has two positive cations, so they can fight against the same channels. Then magnesium has calcium channel blocking effect is proposed. So I checked if it is true or not. So this is my experiment using the high blood pressure model of the rats. We call it spontaneously hypertensive rats. And we give the hydrolyzin, that is direct vasodilators. And then we can see in control groups, the hydrolyzin, of course, can lower the blood pressure, and together with the refract tachycardia. Because of the lowered blood pressure, and then sympathetic nerve is overactivated, so the heart rate will increase after the acute injection of the hydrolyzin. Okay? But when we give the rats the high magnesium diet or magnesium infusion, the blood lowering effect of thiazide is enhanced, as you can see here. The blood pressure lowers far better than the control groups, and we don't observe the reflex tachycardic effect after the acute injection of hydrolyzin. Why? It's possibly because the magnesium can block the calcium channels on the vasculatures, and also the calcium channel in the neurons or end of the sympathetic nerve can be blocked by magnesiums. That's why the norepinephrine release is blocked by magnesiums. So then we don't observe the tachycardic reflex. So to prove that, we measure the voltage-gated calcium current using the neuronal cells, and you can see here when the cells is cultured in high magnesium level compared to the low magnesium levels, the current is suppressed by high magnesium levels. So this strongly suggests that the magnesium not only block the calcium channels in the vasculature, but also block the calcium channels in the neurons, the nerve endings. So this is my proposal, that how the magnesium can block the calcium channels. Calcium channels exist not only the smooth muscle cells, but also the sympathetic nerve endings. So both channels can be blocked by magnesiums. So then the vasculature can be relaxed, and also norepinephrine release is blocked. So in patients who are taking the thiazide, they are deficient. They are likely to develop the hypomagnesium. So the blocking effect of the calcium channels and on both sympathetic nerve endings and vascular smooth muscle cells is reduced. That will cause the constriction of vasculatures. So that will elevate peripheral resistance and also increase the catecholamine levels. So as you know that we use beta blockers to protect the heart from the catecholamine toxicities. But if patient has thiazide and low magnesium levels, they are easily to have the catecholamine toxicity in the heart. So that is possibly because the thiazide is not so effective to prevent development of the heart failure. So we strongly suggest you to use the drugs that has no side effects on the ions, so hypokalemia or hypomagnesiums. So in that case, SGLT2 inhibitors or GLP-1 or those kind of stuffs is effective. And also the mineralocorticoid receptor antagonist can elevate magnesiums, then can block the urinary loss of magnesiums. So I think the mineralocorticoid receptor antagonist has advantages to thiazide in terms of preventing the hypomagnesemia. So this is my last slide. The heart failure, nowadays we treat the established heart failure is treated by the SEI and SGLT2, beta blockers, and ARNIs. But to prevent the development of a heart failure beforehand, so we have to manage those risk factors by treating each risks by each drugs. So, for example, the high blood pressure can be measured, can be treated with ARNIs, MR antagonists, beta blockers, ACE inhibitors, ARBs, and SGLT2 inhibitors. And also diabetes can be treated by SGLT2 inhibitors and GLP-1 agonists. And so as obesity, as I told you in another lectures. And also hyperlipidemia should be treated with statins, and also inflammation should be treated with statins. So far we have the data. And also the cancer-related, in case of cancer-related cardiomyopathy, we have data that ACE inhibitors, ARBs, and beta blockers is effective to prevent the further development of the heart failures. So as the CKDs, ACE, ARBs, SGLT2, and the RNAs, although it's minor, small studies, but those 4 drugs can prevent the further worsening of the renal function in terms of the decline of GFR and also the increase of the proteinuria. Especially ACE inhibitor is very effective to prevent the further development of the proteinuria. So we should use those stuffs, and also we should do more clinical researches how we can prevent the stage A and stage B heart failure patients to prevent the further worsening the stages to stage C and D. Thank you very much for your attention.